Alrighty, hello, my name is Elizabeth Locker, and today we're going to be talking about maintenance therapy. And although I may sound like I need maintenance therapy, I just have allergies, so. So first off, a little respiratory joke. So why did the lung go to school? To become a little smarter at breathing. So yeah, today let's get into maintenance therapy. Okay, so the easiest way to remember these are we got our SABAs, our LABAs, our LAMAs, and our ICSs. So our SABAs are our short-acting bronchodilators, and we'll get into it, but it kind of just means what it sounds like. Bronchodilator meaning like open, like to open, bronchodilate the airway, and short-acting meaning it lasts for a short amount of time. LABA, same thing, to last for a longer amount of time in opening the airways. And then long-acting muscarinic antagonists or agents, we'll kind of go more into those, but that's just what it stands for. And then inhaled corticosteroids, which are an anti-inflammatory agent. Okay, so what the heck is a bronchodilator? So a lot of times, patients will ask you what medication they're receiving, especially in the hospital when they're getting like an aerosol treatment. So bronchodilators play a key role in opening up the airways by altering airway smooth muscle tone and increasing improvement in expiratory flow that reflects widening of the airways. So basically it just means that it helps open or bronchodilate the airways, and then it also increases the airway smooth muscle, which helps with like expiratory flow, because when you're thinking about COPD patients, they have a trouble getting air out, right? So anything that's going to help open things up and help expel air is going to help their overall symptoms. And then kind of like what we talked about in the last video when it comes to like airway reversibility, but also like in exercise, when you think like an asthma exacerbation, when someone is exercising and they're overexerting themselves, or even if it's like really hot outside and they run and then it really, you know, constricts their alveoli and causes like that asthma exacerbation. The same thing can be said for COPD patients, right? So let's say they're exercising and they take their bronchodilator prior to exercising. It can help decrease that dynamic hyperinflation. And then also just, you know, if while they're resting, it can also help increase or decrease that. So there's both LABAs and SABAs that are both bronchodilators. And the LABAs are the long-acting one, and the SABAs are the short-acting. These are primarily used for the treatment of acute bronchospasms and to help patients that are experiencing shortness of breath. So really any of our COPDers, right? Because if they're diagnosed with COPD, then one of their long-term symptoms is going to be like chronic dyspnea. So they're going to need a bronchodilator either daily or multiple times a day, depending on the severity of their symptoms. So I want to go back to SABAs and LABAs. So the reason I keep harping on this is, although on the outpatient side, you'll often see patients that have COPD that take like a LABA, a LAMA, and an inhaled corticosteroid. It's not very common to see on the inpatient side, right? Because a lot of times they come in with those medications, but it's not an inhaler that the hospital has, like the pharmacy. So you'll way more often see SABAs or LABAs and LAMAs and ICSs used separately in the hospital setting, at least from what I've seen, and then also like just based off what I was reading. So a key like short-acting bronchodilator is albuterol, and it can be in the form of an MDI inhaler, a DPI, which is a dry powder inhaler, or a nebulizer treatment, like a breathing treatment. And it usually lasts between 4 and 6 hours. So depending on the severity of the patient's symptoms, you may give them a breathing treatment, you know, Q4 or Q6, just depending on how severe their symptoms are. Levalbuterol is the same thing really as regular albuterol. It's also called Xopenex, but it's more expensive, but it also doesn't have some of the underlying side effects that albuterol does. So one thing that albuterol can cause is an increased heart rate, and for a lot of patients, this is not really a factor, or it might increase their heart just a little bit and they don't notice. But for some patients, the albuterol, they can be sensitive to it, and it can cause like a spike in their heart rate and make them really anxious. So levalbuterol is a better option because of that. It can be found as an MDI or a nebulizer, and it usually lasts about the same amount of time, about 6 hours. Sometimes it can even last longer, like 6 to 8 hours. And then on the LABA side, the long-acting side, we have arformoterol, which is usually found in the nebulizer form, and that can last upwards of 12 hours. So when you think about like the SABA, which is only 4 to 6 hours, versus the LABA, which is 12 hours, it is a substantial difference. And the reason that we have these different medications is usually based off the severity and the needs of the patient. So as we go into like LAMAs and inhaled corticosteroids, you'll see that based off the severity of the patient and their needs, and also how long they've had their disease process, right? So if you've had a diagnosis of COPD for 20 years and you've been smoking for, you know, maybe 50 years, you're going to need a lot more medications versus someone who maybe just started having symptoms of COPD. So arformoterol is found in nebulizer form. It usually lasts upwards of 12 hours. And then salmeterol can be found in MDI or DPI, which is dry powdered inhaler, and that can last upwards of 12 hours. So next we have LAMAs, which are long-acting muscarinic antagonists or agents, also known as LAMAs. They're a type of medicine that help control asthma and other obstructive pulmonary diseases. They're kind of like in conjunction with LABAs. So LAMAs, like they also relax the airway muscles, but they relax the airway muscles by blocking muscarinic receptors on the smooth muscle. And they can be used in combination with inhaled corticosteroids or long-acting beta agonists. So they can help improve lung function and reduce asthma exacerbations. And they're often used in conjunction with something else when it comes to COPD. So you'll often see them, like, especially in the on the inhaler end, you'll see a long-acting beta agonist, a long-acting muscarinic agent, and then an inhaled corticosteroid. And I just included on here some of the key ones, or some of the ones that you might see often. When it comes in combination with other drugs, it's often like fluticasone with umeclidinium, I can never say that word, and vilanterol, which are kind of all ones we've already went over, but you'll see them in combination as a dry powdered inhaler, and those can last upwards of 24 hours. And that's typically with patients with COPD that meet that level of severity, right? So even though we've gradually increased on the time, right, from a SABA to a LABA and then also a LAMA, depending on how severe the symptoms are, it might not work for someone who has they're farther along in their COPD. So then having that combination drug can really be helpful. Sometimes you'll also see like budesonide with formoterol and glycopyrrolate, which are all ones we've already discussed, but you'll see them in combination as an MDI inhaler, and those can last upwards of 12 hours, and are typically used with, or usually used with COPD patients as well. So what is an ICS? So an ICS is an inhaled corticosteroid. These are personally my favorite when learning about, because I love anything that fights inflammation. So inhaled corticosteroids help fight inflammation in the body, specifically in the lungs, when inhaled, and can also help open or widen airways by being anti-inflammatory. So when we think of like anti-inflammatory foods, anti-inflammatory properties, right? Inhaled corticosteroids are just another component of that, that can help fight inflammation in the lungs. For patients with, end-stage COPD that have chronic symptoms, an inhaled corticosteroid is really important, because it's, part of that daily regimen in the routine that can really help them breathe better and make them feel better. Okay, so some factors to consider when initiating an inhaled corticosteroid. So these are just kind of like, almost like a rubric to follow when a patient is continuously presenting, especially in a hospital setting. So like, let's say you work at a hospital and they have like a pulmonary side. You may see a patient present like multiple times over a few months span. Usually at that point, they're, going to be needing an inhaled corticosteroid. So if it's more than 2 per year, they're most likely going to be indicated for an inhaled corticosteroid. Also, their eosinophil level, I can never say that word either, sorry. Eosinophil levels play a part. If you think about inflammation and what puts the body under stress, right? Those levels can also play a factor. Now, if they're low, they would be contraindicated, so we wouldn't want to use an inhaled corticosteroid. And then if they had like numerous reports of pneumonia, so like constantly reoccurring pneumonia, an ICS might not be the best indicator. Also fungal infections, or like any type of like mycobacterial infection, which is basically, it can be a fungal infection as well, but those would not be indicated for inhaled corticosteroids.